Merci and bonsoir. These are only the few words that I know in French, I'm sorry. First of all, of course, thank you very much for the opportunity to be back in Marrakesh after many years, as well for the organizer of the meeting, and of course, Sigma, for inviting me. Even I do not speak French, I got some of your point introducing me. This means that I'm getting old. When you have a good CV, it's good, but usually means that you are getting old. So this is the worst part of the story. What I'm trying to this evening is to share you something new, because I know that just speaking about allogliptin by itself will be boring, because I'm sure that you have been already introduced on DPP-4 inhibitors in general, and particularly on allogliptin. But let's try to see this molecule in a more general context of diabetes management. This is the statement which seems to be mandatory in terms that to reassure, according to the law, that what I'm going to present has been approved and is following the local product information. I'm sure you know this for two reasons. First of all, the IDF Atlas is well known, and every edition is giving us very bad new information. Diabetes is increasing around the world. But I'm sure that if you are clinically involved, you know what is happening, that diabetes is increasing in your office, the number of patients is increasing, your duty is increasing because there are few doctors for many patients. This is happening everywhere in the world. I believe also in Morocco is the same. But what is also important is that, let me be honest, in the last years, we were overwhelmed by the story of protecting against cardiovascular and renal disease in diabetes. This can be done directly with the new drugs, it is correct. But at the end of the day, diabetes is still hyperglycemia. The definition of diabetes, the diagnosis of diabetes is linked to the presence of hyperglycemia. No hyperglycemia, no diabetes. And we have evidence that on the left side you see something very important. What happened in the UK-PDS and the other two trials, Advanced Accord and VADT, in terms of optimizing glycemic control. Surprisingly, in UK-PDS, a good glycemic control was accompanied by a protection against any kind of complications, including cardiovascular complications. While in the other three trials, the story was different, and you remember that Accord was stopped before because there was an increased total mortality. Of course, it seems that probably there was an increased hypoglycemia in the Accord trials, and this was accompanied by high rate of mortality. But on the other hand, this is on the left, on the right side, you see one of the several meta-analyses which have been performed after these three trials went out. And they were showing, when you pulled all the data, that even in people with diabetes already having a previous cardiovascular events, if you improve glycemia, you get a benefit. So in other words, glycemia always is also a risk factor for cardiovascular disease, even in people with a previous cardiovascular events. But also we learned from the DCCT study and also from the UK-PDS that there is a phenomenon very important, the so-called legacy or metabolic effect of hyperglycemia. I think that everybody knows what happens. The level of glycemia at the diagnosis, if is improved, strictly improved, can, of course, impact on the development of complications. But in these two studies, When after the trial, all the population was receiving a good optimal glycemic control, you see that in both cases, in both type 1 and type 2, who had from the beginning a very good glycemic control, still had an advantage in terms of reduced impact of complications, including cardiovascular complications. And this is something very well known today. Many years ago, when I was also in the States, we were studying the story of a metabolic memory. We found out the mechanism behind. And so at the end of the day, what is very important is that early, at the second point, look, early glycemic environment is remembered in the target organs, high kidney, heart, extremities. So means that what you do at the beginning, at the diagnosis, is very important. We have evidence that even, if, for example, in the DCCT headache, what happens at the beginning lasts even over 30 years. So it's very important that from the beginning, you try. It's not working. You try to have very good glycemic control in order to spare after years the effect of metabolic memory. This has been confirmed very recently in a post-hoc analysis of UKPDS. What means this slide? Means that who was decreasing 1% A1C after 1 year had this evolution in terms of complications. Who was decreasing 1 point after 2 years at this evolution? Who was decreasing 1% A1C after some years at this? In other words, as soon as you get the best optimal glycemic control, better is the prognosis to preserve your patients for the complications. How allogliptin can enter in this? You know the story of incretin on glucose homeostasis, but I don't know how much you know about how the incretins were discovered. There was a nice guy, Michael Nauk from Germany, who observed that if you give glucose orally, the effect of insulin secretion was higher compared to if you give glucose intravenously. He was wondering if something released by the gut was during the meal, of course, normally physiological situation, can influence insulin secretion. And after years, the GLP-1 was isolated. And he did something that only a crazy researcher can do. He injected the GLP-1 to himself. But the amount was so high that he had a very deep hypoglycemia. He was at risk to die. But he discovered GLP-1. So I don't know, maybe the balance is still in favor of what he did. At the end of the day, you know that what is important is that these incretins, which are secreted by the gut during the meal, they have a key role not in stimulating insulin, but in preparing beta cells to recognize the increase of glucose. So remember this, the concept of physiological action of the GLP-1 is not to induce insulin secretion, but to prepare the beta cells to secrete. And we have performed several studies showing the presence of GLP-1 resistance and so on, but I will not enter in this. Why this is important? Because of course, if GLP-1 prepares the insulin beta cells to secrete insulin, this is very important. Glucose goes up and insulin is over-secreted. The problem, physiologically, you have a molecule, the DPP-4 inhibitor, which role is to cut GLP-1 in order that GLP-1 cannot work more, because as any hormone cannot last forever, can be stopped in its action. And of course, the problem is that in diabetes, when you have a reduced insulin secretion, the action of a DPP-4 is not good because you have less GLP-1, not in terms of a more concentration, but more in terms of action. And so the idea behind the development of a DPP-4 inhibitor was we stop the action of a DPP-4 with inhibitors and we increase the level, the plasma level of GLP-1. And this is what happens. You inhibit the PP4, you increase the GLP-1. Beta cells having more GLP-1 in the circulation are more sensitized and they are able to secrete better and more insulin. So this is what happens physiologically. Of course, the molecules of which we are speaking is a DPP-4 inhibitor, so clearly the key role of these molecules is to stop the action of DPP-4 inhibitors on GLP-1 to increase the concentration of GLP-1. But at the same time, there is an indirect effect on glucagon because you know glucagon is over-secreted in diabetes. So you have an incretin effect at the end is to get back the balance between insulin secretion and the glucagon secretion. It's too much. Okay. Okay, I hope this is better. Just to define a little bit the molecule better, you need to say that it's a very good DPP-4 inhibitor because achieves and maintains more than 80% inhibition over the DPP-4 over 24 hours. Moreover, of course, increase the activity of GLP-1 and decrease the glucagon, so it's really a DPP-4 inhibitor. But also when it's compared to the others, you see that somehow shows also a better selectivity than others. So this is just to show you something that probably you already know. Allogliptin is a good DPP-4 inhibitor. But what about the effect on glycemia? Also in this case, we have evidence that alone or much better, in combination with the metformin, allogliptin significantly reduces glycemia. And it's very interesting that when it's compared to a sulfonylurea, you see that in the long term, there is more action of DPP-4 inhibitors compared to the sulfonylureas. Sulfonylureas are very good drugs, but they, in long term, you know, they squeeze the beta cells, and usually the use of sulfonylureas in long term is accompanied by a deficit of beta cell secretion. And so this is the meaning of this comparison between allogliptin and sulfonylureas is that there is a better, superior glycemic control in time, particularly because you have higher durability with the DPP-4 inhibitors compared to sulfonylureas. And this, of course, is a clinical relevant if you want to keep glycemia under control. What about the cardiovascular safety? You know that this was the trial. Many trials were performed with the DPP-4 inhibitors. Remember that the DPP-4 inhibitors were almost the first class coming out after years as a new drug for the treatment of diabetes. So it's a safe, but I have to say that even the outcome was non-superiority, meaning, in other words, it's not dangerous. Anyhow, in all these points evaluated in the examining trial, you see that the effect of allogliptin is going in the right direction. Is it going in the favor? There is only a huge standard deviation which is not allowed to have a significance. But what you know, particularly for saxagliptin, was raised the issue that it can induce heart failure. And somehow this was discussed also about allogliptin, but in this study, which is a or a sub-study of the hexamine, you see here that on the contrary, the use of allogliptin was accompanied by a decreased concentration of NT-proBNP, which is an important marker for the heart failure. So the story of allo and heart failure is really over. About the side effects, on the contrary of the previous lecture, because even not understanding the French, I got some issues. There is no problem. The class is very safe, and you see here from the exam that the side effects were not so, were neutral compared to placebo. But also there is a very more recent study comparing allogliptin in the examine again between who was receiving metformin or sulfonylureas. Here we have something intriguing because you see here, first of all, who was on therapy having metformin plus glycoside had a better control, but particularly what we see is that that was really an improvement on cardiovascular outcome and all-cause mortality. This, of course, is really intriguing because this is a subgroup of the examine, which I want to remember you, the outcome was non-inferiority. But when you go for this subgroup, probably having more problems because having 3 drugs, they had more problems, it is emerging that when you have a triple therapy adding allogliptin, something good happens on cardiovascular system. But, okay, probably you already knew this. Let's start to speak about what is new, why this molecule could be today more interesting for clinical practice. The story has changed over time. When we speak about the glycemic control, you know, it's not anymore only A1C. On the contrary, we have strong evidence that A1C is not enough at all. The use of a CGM allowed us to understand that when we speak about glycemic control today, we have to speak what happens after meal, what happens in terms of glucose variability, in terms of time in range. All these aspects of the glycemic control are considered today the perfect management of hyperglycemia. I used this drawing. You know from where it's coming, the drawing. It's a Da Vinci drawing. It's representing the perfection of the measure. This is the meaning of this famous drawing of Leonardo da Vinci. So if we want today to speak about the perfect management of hyperglycemia, we must consider the control of A1C, the control of fasting glucose, the control of postprandial hyperglycemia, the glucose of the risk of hypoglycemia, glucose variability to increase the time in range, which clinically is very important and difficult. But you see here, you have the reference, allogliptin, and show to be able to tackle all these aspects of modern aspect of a glycemic control. So this means that you have more help in a modern management of glycemia because you could be able to tackle all these aspects, which are very important because they are all linked to high risk of complications. Moreover, from the verified study, which was using the vildagliptin, we also learned that in terms of the use of a combination between metformin and vildagliptin, in this case, there was a more sustained beta cell preservation, which hesitated in better glycemic control over time, because the beta cell was preserved. But we have data, very recent, showing
that this is true also for allogliptin. So what is true for Wilda is true also for allogliptin. Take in mind this evidence. What can we do differently in diabetes today? I'm sure you know the ESD algorithm. They suggest to use anytime metformin as background to pay attention to the risk of cardiovascular kidney disease, but also to control glycemia. I was involved in European Society of Cardiology new guidelines, and we decide to say, but if somebody is at diagnosis is at a very high risk, maybe the first drug could not be metformin, you could prefer an SGLT2 on GLP-1. And also the more recent guidelines of ESC. This has been presented and published at the end of August. You see, the concept is the same. Metformin can be in background when the risk of cardiovascular disease is not very high. But, science always is very interesting. No science, the scientists are very interesting. When members of the two guidelines were meeting, and they developed this article, which conclusion was that a discrepancy between the early use or not of metformin is not very important because most people with type 2 diabetes rapidly progress to requiring a combination therapy. I believe that this is also your experience in clinical practice. Very often, you start with one drug, very soon you need another two. And we replied, so in this case, if very soon you need a combination, why do not start immediately with a combination? Because also this can help to integrate, to merge the glucocentric, cardiocentric approach to the management of diabetes. Sorry, in the same patient, you do not have only glucose control or heart disease and kidney. They are together. You need to control for cardiovascular events, kidney complications, but at the end of the day, also to get the best glycemic control. Because do not forget that hyperglycemia is very important for retinopathy and for neuropathy, where there is no treatment available. If you want to preserve your patients from neuropathy, the only strategy is to have a very early good glycemic control. So, if this is the approach, clearly you have to merge the two situations. And we know very well that when you combine allogliptin and metformin in type 2 diabetes, these two drugs, they cooperate because they have different targets on the glycemic control. Let me share one more thought. Sorry, in the hypertension, there are 2 or 3 mechanisms supposed to be involved, and today the modern approach is to start with the combination immediately, lower dose with combination. Well, in diabetes, it is supposed to have 8, at least 8 targets. No? The Fronzo octet, maybe you remember. 8 targets for the disease. Do you believe that you can catch one all with one drug? I don't think so. If you remember that the combination with metformin and allogliptin is very, very efficacious in decreasing glycemia, I think that today we can really suggest that glycemic control occurs together with the paying attention to the cardiovascular kidney risk, but can have something more important. Because if glycemic control is not anymore only A1C, but is more complex, and we know that metformin plus allogliptin can be very helpful, particularly in people not at very high. Sorry, when we speak about people at very high risk for cardiovascular disease, or better, with established cardiovascular disease. or kidney disease, we are speaking about 20–30% of the patients. What about the other 70 they need more glycemic control, that specifically a protection against the cardiovascular kidney complications. This is the percent in the real life. So with this combination, you can be able to tackle the modern aspect of glycemia, but also to improve the durability of glycemic control. In other words, you can help your patients with, from beginning and for long term, better glycemic control, which at the end of the day is to reduce the risk for complications, but I see many young doctors in the room. Look, when I started many years ago, our goal was to reduce mortality. Now, the goal is different. The goal is to guarantee a good quality of life to our patients. I believe that nobody can be happy to not, for example, not have a myocardial infarction, but to live blinded or, let's say, in dialysis every 2 days. So we need really a comprehensive management of diabetes, of which glycemia is a key part. So my recommendation is do not forget that glycemia, the control of glycemia, is still a key in the management of diabetes. And we have, I'm Italian, you know, we are using the hands a lot. We need to optimize glycemic control in a modern way, and this combination can be very helpful. I hope that you can consider what I am sharing, particularly to apply in order to guarantee a better life to your patients. And for these words, I say shukran. Is correct? Okay, shukran.